Incision just behind the umbilicus. Cutting the fat versus blunt dissection. Makes linear all but clearer, surely separates muscle and fat. Stops the fat getting caught with ovarian clamp placement. Always assume there is a large spleen below, so tent high for stab incision. Tent high to extend. I use Mayo for large dogs, Mets for small dogs. Keep checking you are on target, following the linear alba. Use index finger as a hook, and slide uterus up the body wall. With left hand push down on the body wall, and pinch ovary, then swap ovary to right hand. Take a step to the right, and slide index finger down the suspensory ligament. You need to get to rib insertion and press down, breaks in seconds. As you can see now, we have at least another inch of exposure. Most unis don't teach that there are two ligaments. Suspensory runs from the top of the ovary to last rib. Kidney runs from the bottom of the ovary to the kidney. You must not break the renal ligament, only the suspensory. You can tell it's suspensory as you feel yourself go past the kidney. If it ends at the kidney, then it's the wrong one. If you break the kidney one by mistake, you have to be super careful pulling on the ovary, as this will now pull directly on the vessels. As there is no ligament to protect them, you will also get some bleeding from the attachment to the ovary. Make the window in the broad ligament, away from the scary ovarian vessels. You want a translucent area and ideally make it low, so we can drop the first millers. I am holding the ovary while I do this between my index finger and thumb. With the ovarian clamp, don't force it down. Now hold the ovary and walk the ovarian clamp down. Check nothing is caught in the clamp, fat or skin, and then walk it down once more. We now separate the uterus by placing two clamps on the other side, and the cup between them. Make sure with the clamps, you go through the same broad ligament window as the ovarian clamp. You can see this vastly improves our visibility. For the millers, we first wrap the suture around the pedicle. With the left hand, place the suture over the index finger and hold it with your thumb. Now with the other piece, which should be shorter, place it over the index finger, making a cross with the other suture. Hold this with your thumb. Then pass it under the clamp and around the pedicle. And make an identical cross on the index finger. Take the forceps and send them in between both loops are, where the index finger is. And grab the tail, pull the tail back out through the loops. And then taking it in the same direction it initially was. We keep the millers loose and drop the ligature by nudging it down at the back and front. And the once happy it is lower enough, try and rotate the ovarian's clamp by placing a pair of curved forceps in the ovarian clamp handle. So when the ligature is tightened, it will not rise up. Make sure the ligature is as tight as it possibly can be, and follow with 5 to 6 singles. We hold the ovary and raise the ovarian clamp, ensuring we are still clearing the ovary. Now a second Miller's is placed. Now a safe broad ligament window, which is low down and where it is translucent. I nearly always ligate my broad ligaments. However, with this one it seemed a little excessive. With ovary in right hand, slide down the suspensory with your left index. This one is always thicker and harder than the other side, so this was what I do. First, try pushing down at insertion the same as the first suspensory. Second, push from medial to lateral at the base, trying to break it into two pieces and then will be easy to break. Third, his can be very simple and effective with your left index laterally. Slide your finger under the suspensory, hook it and push upwards. Now place the window in the broad ligament, away from the vessels, through a clear translucent area, and fairly low down, so we can then drop the Miller knots lower. Walk down the ovarian clamp and check nothing is caught in the clamp. You can see the amount of exposure you get when you break the suspensory ligament correctly. Place your two clamps above the ovary cut between, and separate the uterus for better exposure. Place your first Millers, then raise the clamp. But still make sure you are clearing the ovary, And now place a second millers as shown. The ovary is held and the ovarian clamp moved closer to it to make room for the second millers. Safely check for no bleeding and then let the pedicle go. On examination of the broad ligament, no vessels were present. As it was avascular, the ligament was just gently torn with forceps. I never use crush beds on the uterus, as some uteruses have fallen pieces with the clamps, and others have bled profusely. The logic behind which type of suture: first, I always place a surgeon's, as has a low risk of cutting through the uterus. Second is a miller's. If I am worried the uterus is fragile, I would go 70% strength, then follow with 100% miller's. If I am confident the uterus is strong, I would place a strong miller's followed by transfixing, either the traditional or the two-string transfixer. I tend to never leave the crush bed on the dog side, because the Danish believe this is more painful for the dog. When the incision is very small, I just tend to close with simple interrupted. And also for the charity dogs where they are not getting the rest and observation, as they wouldn't at home. Sometimes the muscle incision will underrun the skin, so it is wise to get a ligation at top and bottom and the rest follow later. You don't want to pull hard, like a ligation. The muscles should meet snugly together, with no holes. The fat layer is simple continence, but the important factor is that from now on, all knots are either buried or laying flat and covered. Start the fat layer deep superficial on the first side, and then superficial deep the other side, so the knot is hidden. First pass of the thread needs to be deep superficial, and then you can double back superficial deep if needed. I finished with Aberdeen with a to pass at the end. We need to hide this knot, it is probably too close to the end to bury it caudally. So take a bite cranial to the knot, so it lays the knot down cranially. Now you come out at the top at the intradermal position. And now continue caudally with your intradermals. We finish with a surgeon's knot, which is more stable than an Aberdeen, but on the downside harder to bury. The knot has to be buried, otherwise we can get wound breakdown. Trim the tail so there is none, it has to bury near the root of the knot. Ideally leave a small hole before you finish your intradermals, but this can sometimes result in a large hole. So try to wiggle the needle through, so it finds a path of least resistance. Once through, pull a little on the suture, but more try and lift the skin over the knot to bury. If it's not working, pull the knot out and go again. In times of desperation, change to a larger needle, as this will create a larger path for the knot to go down.